Great hospitality extended to me so far. Thank you once again. So I think during the last yesterday lectures by Dr. Ramalingam and masterclass, we all realized how the importance of vocal cord palsy or recurrent laryngeal nerve palsy after thyroidectomy. So it's a burden to laryngologists. As laryngologists, you all know. I think yesterday Dr. Ramalingam showed us his majority of the vocal cord palsy are from thyroidectomy. So we have been performing thyroidectomy for long years. Still, we see a lot of palsy. So as surgeons, can we avoid it or can we minimize it? So as he said, I'm from Sri Lanka, one of the smallest country in the world. But it's a beautiful country. So one of the day, I assume some of you have been to my country, and the others, I warmly welcome you all. So I'm working in the University Hospital KDU, that is a medical faculty associated with the Defense University. So I'm the lecturer, and I'm working as a lecturer and consultant ENT surgeon. So following thyroidectomy, actually one of the most common complications is vocal cord palsy. So during next few minutes, we will be talking about how to prevent this major complication. So I think we have gone through these literatures yesterday. I don't have to repeat them again. So to show you, revision surgery, incident of vocal cord palsy increase up to 14 to 30% according to the yesterday masterclass. So we all know it can be unilateral or bilateral vocal cord palsy. It can be transient or permanent. So this is very important. So if the cord palsy does not recover after 6 months, we call it as permanent vocal cord palsy. So what are the injuries of your vocal cord or recurrent laryngeal nerve? It can be traction injury, or it can be thermal injury, it can be compression injury, or it can be transaction injury. So transaction injury, of course, very difficult to prevent unless you know your anatomy and you are being a good surgeon with good surgical skills. But to prevent traction injuries and thermal injuries, at the same time compression injury may be aided by new techniques. So as we all discussed yesterday, gold standard of our prevention of vocal cord palsy or recurrent laryngeal nerve palsy is our surgical skills and great anatomy skills. So any surgeon who is going to do thyroids, I would rather like to revise your anatomy and get your maximum surgical skills to prevent recurrent laryngeal nerve. And pay utmost respect to the recurrent laryngeal nerve, because that is really debilitating. I think you all have seen that if patient gets bilateral vocal cord palsy. So aiding with these great skills, actually we can use the recurrent laryngeal nerve monitoring. That's the laryngeal nerve monitoring. So either we can use intermittent or continuous nerve monitoring. So why continuous nerve monitoring? For the great years, we have been using intermittent nerve monitoring. Actually, when we do the intermittent, we use a probe to realize or recognize the nerve. So, but with that, in between the nerve dissections, there can be injuries to nerve. So you cannot monitor the recurrent laryngeal nerve during your dissections. At the same time, you will get the nerve dissected and you will identify it later on. But if you can use a continuous intraoperative nerve monitoring, you will be continuously monitor the recurrent laryngeal nerve, and it alerts the surgeon to potential nerve injury, preventing further actions. So it reduces the gap between the monitoring, at the same time minimizing the nerve injury. It monitors the entire recurrent laryngeal nerve. Specifically, it gives a detailed EMG records for your medical legal purpose. So how do we do it? Actually, we have to have 2 electrodes. One is for your vocal cords. So either we can use the pre-formed endotracheal tubes, which are a little expensive for us to use. Otherwise, we can use your conventional endotracheal tube, where the electrodes are wrapped around into 360 degrees into your endotracheal tube, where your vocal cords will be monitored throughout your procedure. So next we need a delta electrode which will go into your vagus nerve, which you have to identify your vagus nerve in carotid sheaths and apply the very flexible delta electrode into your vagus nerve. So vagus nerve will be monitored during the entire procedure. So this is a schematic diagram of how we are doing it. So this is one of my patients where you will be given, the patient will be given automatic current of 1 to 2 milliamperes during the entire procedure, and there will be visual and audible signals coming from your monitor. The wave will be appear as a biphasic wave, you can see that. So according to the international guidelines of nerve monitoring study, if your wave is more than 500 microwaves, it is considered as normal. So at the beginning, you have to get the nerve function and you have to get the baseline level, and you will be monitoring these nerve waves into amplitude and latency. So if the amplitude is going down during a procedure more than 100 microvolts, there is a possibility of your nerve being damage. So you have to do some corrective actions. So if the latency is increased more than 10%, again you consider the nerve is at potential injury. So if, as I told you, you have to get the baseline initially, and then beyond that you have to monitor visually and audically. Both these signals will alert you during the surgical procedure. So this shows if it is a tract or section, obviously any of these methods will not help you, so it's by your gold standard. But if it's a ligature or thermal injury, you have a little time to avoid or correct your procedure. And if it is a compressive or traction injury during the surgical procedure, you have enough time for you to correct your procedure. So if you find your nerve is at risk during your surgical procedure, what can you do? You might have to seek for expert help if you are a junior surgeon, or you can change the dissection method, or you can use further helping aids, maybe a microscope or maybe loops if you are not using already. And at the same time, if it's a unilateral vocal cord palsy, you can delay your surgery and coming back in a later date after recovery if it happens. If not, with more aging for the second surgery. Because you all know bilateral vocal cord palsy is a quite debilitating problem for the patient. So apart from thyroid surgeries, it may be helpful for any head and neck surgery where you are involving recurrent laryngeal nerve and superior laryngeal nerve. Maybe it's helpful for your surgeries as well. And specifically the cardiothoracic surgeries, particularly for the pediatric cardiothoracic surgeries, it has documented literature. And tracheal reconstruction surgeries, the problem is actually we are using distant airway, not the vocal cords. So usage may be limited, but you might be able to use external stimulation electrodes if you are really worried about the recurrent laryngeal nerve palsy. Maybe a redo surgery in your surgical procedure. So there are a couple of studies which I am not going to summarize from all over the country, all over the world actually about the usage of this continuous intraoperative nerve monitoring. So this is a publication by the Royal College of Surgeons of England in general surgery. So they emphasize the continuous vagus nerve monitoring offers significant potential advantage. So this is an article from Korea. This is an article from Italy. So all over the country they are recognizing the importance. So in summary, vocal cord palsy is one of the commonest debilitating complications of the thyroid surgery. Active identification of the recurrent laryngeal nerve is the gold standard of preventing this complication. Intraoperative nerve monitoring assists in preventing vocal cord palsy. Continuous nerve monitoring compared to intermittent ones shows a better predictive of vocal cord paralysis. While in routine thyroid surgeries, continuous intraoperative nerve monitoring is an excellent adjunct to the surgeon. In complex cases, continuous intraoperative nerve monitoring changes from simple support to indispensable tool to assist the surgeon. So, these are my references. Thank you very much. So I have been doing thyroid surgeries for the last 10 years. Thanks to the God or to my hands or my teachers, I have not got a single recurrent laryngeal nerve palsy for so far. So I'm proud of that. At the same time, if you get a nerve palsy, our laryngologists are there to help us. Thank you very much.
কেবল আছে না?